everybody, and a warm welcome to the OncoMind World Autumn Session. I am Luca Guayata, head of the Medical Affairs for Thermo Fisher Scientific, and once again, given the unprecedented time that we're still living in, we're going virtual for this meeting. On behalf of all Thermo Fisher Scientific and all my colleagues, I want to say that we're very happy to offer you once again, one more time, a very interesting and valuable agenda. So thank you all very much for participating today. Hope you have seen the welcome message from our clinical sequencing division president, Garrett Hampton. Garrett condensed all the passion that we have about oncology testing and shared with you how thankful we are to all of you, our customers, our collaborator, and he has also outlined our plan for the future. If you didn't have the opportunity yet, you can access Garrett's video message at any time from the lobby. Now, having said that, it leaves me with the pleasure to moderate today's session. And indeed, I'm looking forward for a very vibrant discussion with a highly engaging Q&A. We have 2 blocks of live presentation divided by breaks. And after the last one, we will have the chance to see my colleague, Andrew, who is connecting live from our laboratories in California. He will demo our GeneXus system. You will be able to ask him questions as well as to our speaker, who will be live in the studio with me at the end of every block of presentation. And now, of course, even more for you, don't forget to see the OncoMind Solution Hall, All Precision Oncology Hall, and our brand new posters in the poster hall. After the live presentation, there will be our Thermo Fisher expert waiting for you in the Ask the Expert room. So please take the opportunity and go and connect with my colleague. And now, with no further delay, let me introduce the first general educational session. And the first speaker for today, Dr. Aaron Tan. Thank you again very much for joining us today. Enjoy the meeting.
So thank you for the invitation to speak today. My name's Aaron Tan. I'm a medical oncologist currently working at the National Cancer Center, Singapore. I'll be presenting on incorporating next generation sequencing, or NGS, in an Asian non-small cell lung cancer population, including a cost-effectiveness analysis. So these are just the disclaimers and disclosures. So I start with what is basically a pretty basic concept that probably everyone already understands, that cancer is fundamentally a genetic disease. So on the left, we've got a picture of a Brazilian ophthalmologist who 150 years ago was actually the first to describe a family with hereditary retinoblastoma. On the right, there's a picture of Watson and Crick, who of course discovered the double helix structure of DNA. But I start with this concept just because it shapes the way that we view genomic profiling. That genomic profiling should really be there to uncover the biology of disease that then enables us to implement precision oncology. So really, it's more than just identifying a biomarker to identify a treatment for a patient, but it's really there to uncover the biology of disease. And this is perhaps a subtle distinction in terms of the way that we view genomic profiling, but I think important all the same, because it does contextualize the way that we view molecular profiling and how it may be integrated into clinical practice. So the outline of my talk today, I'll be going through what I feel are some of the key considerations for the routine implementation of next generation sequencing. And that includes clinical utility, feasibility, cost effectiveness, and diagnostic accuracy. And obviously I'll be using non-small cell lung cancer as the illustrative example for the implementation of routine next generation sequencing. So I start with this slide, which basically just demonstrates a pie chart of non-small cell lung cancer and the way that our understanding of different molecular subgroups within non-small cell lung cancer has changed over the years. Obviously, we know that there are significant proportions of patients that have oncogenic driver mutations in genes such as KRAS and EGFR, but there are now a whole range of other smaller proportions of patients that have oncogenic drivers or biomarkers in other genes, including mutations in BRAF, HER2, as well as fusions in genes such as ALK, ROS1, and RET. But even this pie chart from 2019 perhaps underestimates the true complexity of the different molecular subgroups. For example, NTRK fusions, NRG1 fusions are not listed here. And of course, there's the emerging immunotherapy biomarkers. There's PD-L1, which is already used in routine clinical practice, but also other biomarkers such as MSI status and tumor mutation burden. And obviously, these molecular subgroups are important to identify because there is an expanding list of approved and emerging therapies for non-small cell lung cancer and the different molecular subgroups. So if we come back to this pie chart, where 10 to 15 years ago, treatment options were largely limited to cytotoxic chemotherapy, there's now an entire range of different targeted therapies, immunotherapies, anti-angiogenic therapies that are approved or have emerging clinical data in early phase clinical trials. So it really just underlines how fast the landscape in terms of the non-small cell lung cancer treatment has changed and how we do need to move forward in terms of identifying these alterations in patients so that they can then receive the most appropriate first-line, second-line therapies. So obviously that also means that our testing paradigms do need to move with the changing dynamics of the treatment landscape. However, currently the standard of care testing paradigms would be pretty similar for most countries around the world and are still largely limited to testing for EGFR mutations, ALK rearrangements, and ROS1 rearrangements in non-squamous cell carcinomas. In squamous cell carcinomas, many guidelines still don't even routinely recommend testing for these various molecular subgroups and oncogenic drivers. BRAF mutations are recommended in some guidelines around the world, but obviously there are a whole range of oncogenic drivers which have approved therapies or emerging therapies that are important to identify so that, as mentioned, patients can receive the most appropriate targeted therapy and most appropriate treatment for improving their long-term outcomes. So obviously that's where next generation sequencing comes in. It has many advantages in terms of being able to detect multiple different alterations within a single workflow, although there are obviously challenges in terms of how we implement next generation sequencing in routine clinical practice. And that's not just limited to the potential costs of NGS itself, but also the expertise and the knowledge in terms of establishing next generation sequencing within a pathology laboratory. So that brings me to I suppose, what I consider to be some of the key considerations for the routine clinical implementation of NGS. And as mentioned, I'll go through these 4 different key areas. So firstly, I'll focus on clinical utility of NGS. So for that, I'll start with a brief description of the National Lung Profiling Study, which we conducted here in Singapore. It was done under the auspices of the Lung Cancer Consortium Singapore. So this was a retrospective cohort study conducted in newly diagnosed, treatment-naive, non-small cell lung cancer patients over a period of about 18 months in 2016 to 2017. Patients that had been diagnosed at the National Cancer Centre Singapore or Singapore General Hospital, and patients that had available archival FFPE tissue. So this is the consort diagram here, which demonstrates that there were 174 patients that were eligible for the study. And of these patients, we performed NGS testing with DNA in 173. We performed RNA fusion testing in 119 of these patients, and also PD-L1 immunohistochemistry in 169 patients. So to start with, we looked at a comparative analysis in terms of what was the routine or standard molecular profiling at the time versus the results that we got from the next generation sequencing assays. So the routine molecular profiling at the time included EGFR testing, either through Sanger sequencing or Cobas RT-PCR, and also included what we termed as quad FISH, so looking for fusions in ALK, ROS1, and RET, and amplifications in MET using FISH assays. Obviously, we compared this to the next generation sequencing results, and we used what was termed the SSTP panel, or the somatic solid tumor panel. And this was a DNA-based NGS test, which looked at 29 different genes, which are listed on the bottom, as well as the RNA fusion testing using a lung fusion panel. As mentioned, most patients also had PD-L1 immunohistochemistry to look for the tumor proportion score. So if we look at the comparison between the standard molecular profiling and the next generation sequencing results, the first thing to mention, I suppose, is that in an Asian population in Singapore, there were obviously high rates of EGFR mutant patients. So upwards of 61% of patients had the presence of an EGFR mutation, and obviously smaller proportions of patients with ALK fusions, ROS1 fusions, and RET fusions detected by FISH. The remaining patients can also be stratified in terms of their PD-L1 TPS listed there. And when we compared that with the next generation sequencing results, we can see that the next generation sequencing performed well in terms of the identification of these alterations. But in fact, there were more patients that were identified as having oncogenic driver mutations in EGFR that were targetable. So NGS was able to identify additional patients who would benefit from first-line EGFR TKI therapy, and obviously avoiding the need for upfront cytotoxic chemotherapy or even the combination with immunotherapy, which we know is not as effective in EGFR mutant patients. So this really just demonstrates the clinical utility of NGS in an Asian population, including an EGFR mutant predominant non-small cell lung cancer population. So next, we'll also look at the feasibility and cost effectiveness in terms of implementing NGS. And from our NLP study, we also looked at a cost effectiveness analysis. So we looked at a couple of different potential testing strategies, including two of them which were shown in the diagram here. So on the top panel, we've got sequential or singleplex testing. So with such a high proportion of patients with EGFR mutations, there perhaps can be some argument that the ideal testing strategy should look for EGFR mutations first, whether it be through Sanger sequencing or PCR testing, and only in the patients that are negative, then performing sequential NGS testing. However, the other testing approach could obviously be upfront NGS testing, including PD-L1 immunohistochemistry, and then allowing patients to go on to the appropriate therapy. So if we look at, the panel on the right demonstrates the identification of actionable alterations using both testing strategies. And we can see the performance of both either the sequential singleplex testing or upfront NGS performed quite similarly. But when we consider the costs of each approach in terms of a per patient cost, and this is in Singapore dollars, we can actually see that the upfront NGS approach doesn't add a significant amount of costs per patient, really demonstrating that upfront NGS can actually be just as cost effective as the sequential singleplex testing in terms of our patient population. And this is even in, as I mentioned, an EGFR mutant predominant non-small cell lung cancer population. But there are obviously other factors to consider as well. So on the bottom panel, we've got the turnaround time in terms of the time taken for results to come back. And again, if we consider the upfront NGS testing strategy, you can see that we get results back for most patients within 10 to 15 days. The sequential approach, however, can lead to additional time in terms of the turnaround time, particularly for patients that are EGFR negative. Patients that then go on to sequential NGS can be waiting up to 20 to 25 days before they actually get any results back for the presence of targetable mutations. And obviously patients that are metastatic or advanced non-small cell lung cancer, a time period of 3 to 4 weeks can be too long to wait for the appropriate results. But these patients can deteriorate within that time. Again, some other considerations in terms of this cost-effective analysis. Obviously, there's also in terms of the assay logistics. So just the expertise and the costs in terms of having multiple different assays, such as the EGFR, PCR, as well as NGS, whereas with the upfront NGS testing, there's only the requirement for the NGS itself. And there's also the consideration of the issue of repeat biopsies and tissue attrition. So with the sequential approach, if there's tissue that has been used for EGFR testing, leading to potentially insufficient tissue for sequential NGS, these patients may then need to potentially undergo repeat biopsies, which obviously further lengthens that turnaround time. So this really demonstrates how the implementation of NGS can be both feasible and cost-effective, and particularly for non-small cell lung cancer, where there are such a range of targetable alterations, it can be an important consideration in terms of its implementation. So finally, I'll also look in terms of the diagnostic accuracy. So for this, I'll use the example of RET fusion positive non-small cell lung cancer. So RET fusions have been a known target in non-small cell lung cancer since 2011. Occurs in approximately 2% of patients with non-small cell lung cancer, but hasn't been routinely recommended for testing in terms of newly diagnosed patients due to the poor efficacy of multi-kinase RET inhibitors. That's of course now changing, and on the waterfall plot on the right, we can see the results for selpercatinib, which is a selective RET inhibitor. And we can see quite impressive response rates in terms of 70 to 80% response rates, demonstrating how the treatment landscape is changing. And now, these drugs are now approved, increasing the importance of identifying these alterations. But actually, there is no gold standard for the diagnosis of RET fusions. Traditionally, FISH has been used in much of the literature, but the interpretation of the FISH assay for RET fusions can actually be quite challenging due to the small distance in terms of the break-apart probes in the FISH assay itself. And there is some suggestion that perhaps NGS testing may have better sensitivity, although there are other assays and techniques with which you can diagnose RET fusions, such as PCR, but there actually have not been many large-scale studies comparing different testing methods. So we went back and looked at our retrospectively our cohort of patients that had RET fusions, and we identified 64 patients that had RET fusion positive non-small cell lung cancer, and we compared the performance of the FISH assay versus the NGS assay. So we identified out of the 64 patients, 13 patients that had both NGS and FISH testing performed. And we can see that actually there were quite high rates of discordance between the two assays. Furthermore, when we looked at the criteria to diagnose a FISH result as positive, if we considered that there is perhaps this equivocal result where only 10 to 15% of tumor cells may be positive on the FISH, we can see that over half of these patients that had both assays performed actually had discordant results between the NGS and the FISH. And obviously that can be critically important for these particular patients in terms of FISH positive only but negative on NGS. Perhaps this could be a false positive, leading to inappropriate first-line therapies and ineffective first-line therapies in terms of the RET inhibitors. And in terms of the patients that were NGS positive only, perhaps FISH testing may have seen these patients as false negatives, again, leading to potentially ineffective first-line therapies in these patients. We also further went and looked in terms of how these patients, in terms of their survival, and a majority of these patients did manage to receive selective RET tyrosine kinase inhibitor therapy because we had a few of these trials open at our center. And we can see that patients that had received selective RET TKI therapy, it was associated with a better overall survival outcome, just demonstrating the importance of identifying these alterations in these patients so that they can receive effective therapies. So that covers what I consider to be the four of the key considerations in terms of the routine clinical implementation of next generation sequencing in terms of the diagnosis of non-small cell lung cancer. But obviously there are potentially further applications of NGS, not only in non-small cell lung cancer, but obviously in other tumor types as well. And this comes back to the point I made in the beginning, that really genomic profiling should be there to uncover the biology of disease so that we can then identify the most appropriate therapies for our patients to lead to better outcomes. So one of the potential applications is to identify co-alterations that could be either prognostic or predictive in terms of selecting therapies. And again, we use the example of metastatic EGFR mutant non-small cell lung cancer. So when 10 to 15 years ago, the options were limited to chemotherapy, obviously there are now a range of different options for these patients, and the treatment landscape is becoming more and more complex. There's not only first-line EGFR TKIs, there are different generations of EGFR TKIs, including first, second, and third generation inhibitors. There are also combination approaches and that have shown clinical benefit in phase 3 clinical trials. And this includes combinations with chemotherapy, combinations with anti-angiogenic agents as well. So the treatment landscape is becoming increasingly complex. And there are already baseline factors that we can use to determine what might be the best approach in certain patients. So at the moment, clinically, particularly the presence of brain metastases or CNS metastases can indicate that potentially third generation EGFR TKIs may be the better first-line treatment option compared to first generation TKIs. But there are other potentially important prognostic or predictive biomarkers, perhaps not quite yet in terms of routine clinical practice, but may in the near future become important to identify. That includes co-alterations or co-mutations, for example, P53 mutations, amplifications in HER2 or MET, but it may also include potentially broader genomic traits, including things like genome instability with whole genome doubling, tumor mutation burden, and potentially even chromosomal instability. So again, we use the example from our national lung profiling NLP study. And from that study, the 174 patients, we identified the patients that had received first-line EGFR TKI. And we can see that patients that had co-alterations in P53 had shorter progression-free survival on first-line EGFR TKI. And this mirrors what we know from the literature. And although, as mentioned, it may not yet be in routine clinical practice in terms of how it determines our first-line treatment options, it may in the near future become important. So what else can NGS provide in terms of understanding the tumor biology? Obviously, there's also tumor evolution in terms of resistance and the potential for understanding or optimizing the sequencing of treatments as well. Again, using EGFR mutant non-small cell lung cancer as the example, we know that, for example, in resistance to third generation EGFR TKIs such as osimertinib, there can be a whole range of potential resistance mechanisms. And the important thing to note is the presence of potentially targetable resistance alterations. So just highlighting the example of the 3 to 10% of patients that have targetable resistance fusions. So fusions in genes such as NTRK, RET, ALK, and BRAF. And obviously there are approved therapies for that target these resistance alterations. And there are case reports of patients responding to these targeted therapies. If we also consider resistance to ALK TKIs, and although this is in vitro or cell line data, we can see on the left a range of different potential ALK resistance mutations. And if we consider, for example, the G1202R resistance mutation on the panel at the top, we can see different ALK TKIs. Perhaps this is a resistance mutation that may only respond to lorlatinib therapy. So we can see how NGS can also be important in potentially understanding how patients' tumors become resistant to therapies, evolve, and how we can then select better next treatment options. So just the final 1 to 2 slides. Where can we see next generation sequencing coming in the future? And I think if we come back again to that point I made at the beginning, that next generation sequencing is there to understand the biology of disease, I think we will likely see next generation sequencing coming in terms of looking at the broader genomic profile of patients. And that includes potentially whole exome sequencing and whole genome sequencing, but may also include other multi-omics layers as well. So transcriptomics with RNA sequencing and potentially also epigenomics as well. So to finish, again, just coming back to that central point, that really next generation sequencing, molecular profiling or genomic profiling is there so that we can understand the biology of our patient's disease. And this is what enables us to implement precision oncology. So with that, I thank you for listening, and obviously free to take any questions or comments as well.
Good morning, my name is Natalie and I'm an Associate Consultant in Medical Oncology at the National University Cancer Institute in Singapore. Today I'll be sharing an overview of the role of PARP inhibitors and relevance of HRD testing in advanced ovarian cancer. So this is a disclosure. Thermo Fisher is not endorsing or recommending, promoting any use of or application of Thermo Fisher scientific products presented by third parties during this seminar. And these are my disclosures. So ovarian cancer is the most lethal of the gynecologic malignancies in the developed world, and each year close to 300,000 new cases are diagnosed worldwide. Advanced cancer, referring to stage 3 and 4 ovarian cancer, accounts for 70% of diagnosed cases. And this is usually because there's a lack of effective population screening programs, and many patients do have non-specific symptoms at the time of presentation, which may lead to a delay in diagnosis. In the published literature, we know that around 75% of all advanced ovarian cancer patients are of high-grade serous histology. Now, in our center and in other East Asian countries, this distribution is slightly different. We tend to have a higher representation of clear cell carcinoma subtype patients, but high-grade serous ovarian cancer still accounts for up to 50% of diagnosed cases in our center. It's also important to recognize that high-grade serous ovarian cancer is a molecularly heterogeneous disease. And while TP53 mutations are ubiquitous in high-grade serous ovarian cancer, we do recognize that around half of high-grade serous ovarian cancers are characterized by genomic instability due to a spectrum of deficiencies in homologous recombination DNA repair. And when we look at the specific reasons for HR deficiency or HRD, we can see that around 20% of HRD is attributable to germline or somatic mutations in germline or somatic mutations in BRCA 1 and 2, and these are central players in the homologous recombination DNA repair pathway, whereby 30% of the rest of the patients with HRD are usually related to underlying epigenetic changes in BRCA1 or other mutations in other HR-related genes. So let's just go one step back and recap how HRDNA repair is important in maintaining genomic fidelity. And we know that maintaining genomic integrity is really of utmost importance to our cells, which have evolved a number of sophisticated pathways to repair both single-stranded and double-stranded DNA breaks. And these are represented in the green and the orange boxes on the slide. Now, single-stranded DNA breaks are more common in our cells, and if these are not repaired efficiently, these are commonly broken down into double-stranded DNA breaks, which are more genotoxic to the cell. So single-stranded DNA breaks are usually repaired by certain pathways represented in the green boxes, and double-stranded DNA breaks are repaired by DNA repair processes represented in the orange boxes. Of the double-stranded DNA repair pathways, we know that homologous recombination represents a high-fidelity repair system that allows for accurate DNA damage reparation. However, if a cell is deficient in homologous recombination, that means that they become more reliant on other methods of DNA repair, such as non-homologous end joining or single-strand annealing, and these are low-fidelity DNA repair mechanisms that are error-prone. And these consequently lead to the buildup of genomic instability within the cell. Now, the presence of HRD in the cell has been recognized as a targetable vulnerability, whereby PARP inhibitors may be administered to induce synthetic lethality in the right genomic context. PARP inhibitors are small molecule inhibitors of PARP1 and PARP2, and when PARP inhibitors are introduced, they trap PARP at the sites of single-stranded DNA breaks and block base excision repair. And the lack of single-stranded break repair often leads to double-stranded DNA breaks, which are more genotoxic to the cell. And in cells that have deficiencies in homologous recombination, they are unable to repair the double-stranded breaks efficiently, and that often leads to selective cell death in the HRD-affected cells. So understanding this has led to the development of PARP inhibitors. As we can see in the red circle, there are 3 different PARP inhibitors that are approved for use in advanced ovarian cancer. And on this slide, we have organized the PARP inhibitors in decreasing level of PARP trapping potency, whereby of these 3 PARP inhibitors, niraparib is the most potent to trap PARP1, whereas rucaparib and olaparib have fairly similar PARP trapping potencies. Now, another important question that is being asked is what is the best way to define HRDness or HRD positivity amongst high-grade serous ovarian cancers? And to this day, there's no gold standard assessment. HRD is commonly recognized as a spectrum across high-grade serous ovarian cancer, and many different tools are under investigation to see how well they discriminate patients who are HRD positive versus negative. Now, the first bullet point shows 2 different commercially available assays that have been developed and validated on prospective clinical trials. And this would be the Foundation Medicine % LOH, as well as the Myriad My Choice assay. And both of them are available for prescription, for purchase, and for reimbursement in certain countries. But aside from these 2 assays, many other different assays are undergoing preclinical and clinical investigation. So the commercially available Myriad My Choice test uses next generation sequencing of DNA and analyzes 3 factors to come up with a GIS score, or a genomic instability score. And they essentially use 3 factors to determine the score. The first factor is LOH, or loss of heterozygosity, that indicates the presence of a single allele. The second score is a telomere imbalance, which indicates a discrepancy in the 1:1 ratio at the telomeres. And finally, there's a large-scale transition, or LST, score that looks at transition points between regions of abnormal and normal DNA. And the overall HRD score, or the overall GIS score, is calculated by adding up these 3 scores by a certain formula. And this gives actually a continuous score between 0 to 100. And a positive HRD score is defined as anything that is 42 and above. And this has been tested prospectively in frontline and later line maintenance settings. So the Myriad test also provides a tumor BRCA1 and 2 mutation status. Now, the other commercially available HRD test is the Foundation Medicine percentage LOH. And I think it's important to recognize that the way the Foundation Medicine test is developed and analyzes for HRD is fundamentally different from the Myriad My Choice test. Now, we're familiar with the Foundation 1 CDX panel. This provides NGS of more than 300 cancer-related genes, including BRCA1, 2, and other HRD-related genes. It also provides the % LOH score and other biomarkers like the TMB, tumor mutational burden, as well as the MSI, microsatellite instability status. Now, how they measure the LOH on Foundation Medicine is actually very different to the Myriad test. Rather than looking at individual LOH events, the Foundation Medicine test looks at the % of the genome that's affected by LOH. And this is inferred across the 22 autosomal chromosomes. Positivity, or HRD positivity, is regarded as a score of 16 and above, whereas a patient with a genomic LOH score less than 16 is represented by LOH low on this test result. If the LOH score is indeterminable, they will mark this as a LOH unknown. So as mentioned earlier, using these two commercially available assays, we have seen in key trials across different disease settings that the benefit retrieved by different groups of molecularly defined ovarian cancer patients appears to be quite different. Again, the BRCA mutated patients appear to benefit the most. The HRD positive BRCA 1-2 wild type patients appear to have an intermediate benefit, and the BRCA wild type HRD negative patients appear to have the least benefit across different phases of the ovarian cancer treatment spectrum. So let's look at some of the key trials that stratified patients by BRCA status and HRD status, and look at the impact of this stratification on the benefit that was retrieved by patients in various outcomes. So the first study I'm going to discuss briefly is the Quadra study, and this is actually a study of niraparib in late-line treatment for ovarian cancer. And this was actually a single-arm study, phase 2 study that incorporated around 400 patients, and they looked at patients that were fairly heavily pretreated, that had relapsed ovarian cancer, and that had 3 or more lines of prior chemotherapy. And 2/3 of these patients were actually resistant to the last line of platinum therapy. And all patients underwent the Myriad My Choice test, as well as germline BRCA testing, and they were denoted to be HRD positive if the GIS score was more than 42. And patients were treated with daily niraparib at 300 milligrams. The primary endpoint was the objective response rate. So what we can see is that amongst patients who are sensitive to the most recent line of platinum, and amongst patients who are resistant or refractory to the most recent line of platinum, there is a very clear difference in the benefit between each genomically defined group. So as we can see, the BRCA mutated patients, they have the highest response rate amongst platinum sensitive patients compared to the HRD positive patients that had an intermediate response rate, and the HRD negative patients virtually didn't respond to this strategy. And similarly, amongst the platinum-resistant patients, although the BRCA, the response rates in the BRCA-mutated population is less than those that were platinum-sensitive, 27 versus 39, this was still more than the HRD-positive patients, within the platinum-resistant subgroup of patients. And again, the HRD-negative or unknown patients didn't appear to benefit at all. Now, moving forward in the disease, in the treatment spectrum, again, when we look at patients who have platinum-sensitive relapsed ovarian cancer, there were several trials that showed the benefit of maintenance PARP inhibitors after platinum chemotherapy in platinum-sensitive relapsed ovarian cancer. And one of these trials was the NOVA trial. And this was actually a randomized phase 3 trial that, again, took patients who had platinum-sensitive relapse, gave them chemotherapy. Patients who are in CR or PR to the platinum-based chemotherapy were randomized to niraparib maintenance until progression or placebo. And overall, the trial was positive for the primary endpoint, which is progression-free survival. But what was quite interesting is that when they used the Myriad My Choice score as well as the genomic BRCA status and actually split the patients into different subgroups, they could see again that the benefit that was retrieved by these patients was quite different. So we can see that the germline BRCA mutant patients had the lowest hazard ratio and the widest separation between the curves, indicating that they retrieved the most benefit in terms of progression-free survival from the use of niraparib maintenance. And amongst the patients that were non-BRCA mutant, that is, they were BRCA wild type, when they split them into HRD positive and HRD negative, again, we can see that patients who are HRD positive, they have an intermediate hazard ratio between the BRCA mutants and the HRD wild type patients, HRD negative patients. And again, the HRD negative patients benefited the least, although across all subgroups, all patients did benefit. So although the HRD test in this setting was not useful to select patients that benefit because all patients benefited as long as they were platinum responsive, it did tell us that it would tell us about the magnitude of benefit that would be retrieved by a particular patient that is being treated with such a strategy. So there were two other randomized phase 3 studies that did look at other PARP inhibitors in a very similar way. One was a phase 2 study, that was the study 19. And another was a phase 3 study, the ARO3 study, and that essentially led to the approval of rucaparib, olaparib, and niraparib as maintenance treatment for relapsed ovarian cancer that was in complete or partial response to the latest platinum chemotherapy, without the need of a companion diagnostic to prescribe the PARP inhibitor. But the HRD test at this point does inform us about the magnitude of PFS benefit that the patient is likely to retrieve. So this is one of those trials that I mentioned earlier, the ARO3 study. And this trial, instead of using the Myriad My Choice test, actually used the FMI % LOH. And it was a very similar trial design. It was a randomized phase 3 design. And again, they randomized patients to rucaparib after response to platinum chemotherapy versus placebo in the platinum, mostly platinum sensitive relapsed ovarian cancer setting. And again, very similar results. All patients benefited from the use of a PARP inhibitor compared to placebo, as long as they were platinum sensitive. But again, BRCA mutant patients benefited the most, with the widest separation between the curves and the lowest hazard ratio, compared to the BRCA wild type and HRD negative group, who had the highest hazard ratio amongst the three subgroups. And here they use the FMI % LOH test. And again, LOH high was defined as a % LOH of 16 or more. So again, this, these two trials and another trial led to the approval of 3 different PARP inhibitors as maintenance treatment in relapsed ovarian cancer that is sensitive to the last line of platinum therapy, without the need for a specific companion diagnostic. And so just looking at how PARP inhibitor development in advanced ovarian cancer went up until June last year, again, we can see that in later line, it was approved for BRCA mutant patients. In the platinum sensitive, platinum responsive setting, it was approved irrespective of platinum status, irrespective of HRD status. Patients just need to be platinum responsive, and a companion diagnostic is not required. And also a bit earlier to June 2019, there was also another trial that did look at frontline maintenance PARP inhibitors, but exclusively in BRCA mutant patients, again showing benefit. And so up to June 2019, again, in order to prescribe frontline PARP inhibitor maintenance, we just needed the BRCA mutation status, and we didn't require a HRD test. And the role of HRD testing really came after 3 separate randomized phase 3 designs were presented at ESMO last year. And I'm going to go through 2 of the trials that I think were the most impactful. So the first trial was the Paula one, and this actually recruited patients that had undergone debulking surgery, either primary debulking surgery or interval debulking surgery. And these patients all had been treated with platinum taxane-based frontline treatment, as we would do. Patients would have received at least 3 cycles of bevacizumab concurrent with the chemotherapy. And if they had responded to the treatment, and if they were either with no evaluable disease or in complete or partial response after the frontline treatment, they were randomized to either olaparib bev or bevacizumab with placebo. And the olaparib or placebo was given for 2 years, and the bevacizumab was given for 1 year. And the primary endpoint here was progression-free survival. Prospectively, patients also had tumor BRCA mutation status performed. They also had the Myriad My Choice HRD test performed. Now, the second trial is the PRIMA trial, and this study recruited advanced ovarian cancer patients with, but specifically those with a high risk for recurrence. And very similar to the Paula 1 study, these patients had surgery, they had first-line chemotherapy, and patients who were either NED in CR or PR to frontline treatment were randomized to either niraparib or placebo. And here the niraparib was continued for 36 months and was dosed according to weight and platelet. And the primary endpoint was also progression-free survival, and they did a hierarchical testing in patients with HRD positive tumors first, followed by the overall population. So just looking at these 2 trials, this is the distribution of patients who are BRCA mutated and HRD positive on both the PRIMA and the Paula 1 trials. And we can see that around 30% of patients were BRCA mutants on both trials, which is a bit higher than what we expect in the general population. And the HRD positivity was also seen in around 50% of both trials. Okay, and this HRD positivity was analyzed using the Myriad My Choice test using a GIS score of 42 or higher. So that leaves approximately 30% or 40% of patients being HRD negative or HR proficient, because around 15 to 18% of patients had an unknown HRD status. Okay, and these are the results from these 2 trials. So looking at the Paula 1 study, I think the overall results were actually positive in the intention to treat subgroup. But what was most interesting is when they analyzed the results by the HRD status and by the BRCA mutation status. So it was, again, obvious on this trial that patients with BRCA mutations on the left-hand side of the slide benefited the most from the use of a maintenance PARP inhibitor after chemotherapy, with the widest separation of the curves and a hazard ratio of 0.33. And patients, on the middle curve who are HRD positive but who are BRCA wild type, these patients had an intermediate benefit with also a really impressive hazard ratio of 0.43. But when we looked at patients who were Myriad My Choice GIS score of less than 42 or HRD negative, this population was, we were unable to demonstrate a benefit of adding olaparib to bevacizumab in this population. The hazard ratio was 0.92 and the confidence interval crossed 1. And when we looked at the PRIMA trial that studied niraparib after frontline chemotherapy, again, when they looked at different subgroups of patients, the BRCA mutant patients, the HRD positive BRCA wild type patients, and the HR proficient patients, again, we can see that the degree of benefit or the magnitude of benefit was the most in the patients with BRCA mutations with a hazard ratio of 0.4. Again, there was a good benefit, but lesser in the BRCA wild type HRD positive population. And in the HR proficient population, there was still a statistically significant benefit with a hazard ratio of 0.68 and a confidence interval not crossing 1. But the benefit was markedly less compared to the HRD positive and the BRCA mutant subgroups. And so therefore, on both frontline studies, the PAOLA-1 and the PRIMA-1 of maintenance PARP inhibitor after frontline chemotherapy in all-comer patients, we do see that when we look specifically at the BRCA mutant subgroup patients, we can see that the hazard ratios are 0.3 and 0.4. And when we compare this with the SOLO-1 study, as mentioned earlier, this was a study of olaparib versus placebo, specifically in BRCA mutant patients. Again, we can see the hazard ratio is also fairly similar at 0.3. And so what can be firmly concluded from PRIMA and PAOLA-1, in addition to SOLO-1, is that all patients with BRCA mutant ovarian cancer should be offered PARP inhibitor maintenance therapy after frontline chemotherapy. And this effectively means that all patients with newly diagnosed ovarian cancer really need to have early somatic and germline BRCA testing for us to be able to adequately define this group of BRCA mutant patients who are really going to benefit from the use of a maintenance PARP inhibitor strategy. And again, looking at the HRD positive subgroup that was BRCA wild type, again, this represents this group of patients in the white part of the circle who are HRD positive but non-BRCA mutants. Again, between the PAOLA-1 and the PRIMA study, we can see the hazard ratios are also fairly similar, 0.43 and 0.5. And these patients, they do benefit from the addition of a PARP inhibitor as a maintenance strategy. And so effectively, these two trials do show us that doing a HRD test and trying to define this group of patients that are HRD positive but BRCA wild type will also help us to select the right patients for maintenance PARP inhibitor strategy in frontline. Now, for patients who are HR proficient or HRD negative, the evidence is conflicting between the two trials. While the PAOLA-1 study didn't show any benefit for the addition of olaparib to bevacizumab for this group of patients, the PRIMA trial did show that adding niraparib compared to placebo does improve progression-free survival, albeit for a fairly short absolute period of time of 2.7 months. And I think the questions that remain unanswered are, is this PFS benefit from niraparib? It's statistically significant, but is it truly clinically significant? And in this high-risk population that was enrolled on PRIMA, these are typically the patients that we would consider prescribing bevacizumab to as frontline and also maintenance. We don't know if niraparib is superior to bevacizumab in this subgroup. And I think further clinical trials are warranted in this HR proficient subgroup of patients. And so in April this year, we had 2 new FDA approvals, basically olaparib, in addition to bevacizumab, has been approved for frontline maintenance treatment for patients who are in complete or partial response to frontline platinum-based chemotherapy and whose cancer is either BRCA mutated or has a HRD positive test. And FDA also approved the use of niraparib for the maintenance treatment of all ovarian cancer patients, regardless of HRD therapy. But again, going back to this slide, again, we do ask whether the PFS benefit is clinically significant and whether this is truly the optimal maintenance strategy for patients who are HR proficient. So compared to previously, where HR testing was not required to select patients for PARP inhibitor therapy in the platinum responsive setting or in the later line setting, We now know that HRD testing is important to help us to select the optimal maintenance strategy for patients in the frontline setting. And so to summarize, essentially what these trials mean is that upfront BRCA and HRD testing is important for us to make clinical decisions on maintenance treatment following frontline systemic therapy. And patients with BRCA mutants will offer them PARP inhibitor maintenance, whether this is olaparib plus bevacizumab, or niraparib. If patients are HRD positive, we would also offer them PARP inhibitor maintenance, and this may be niraparib or olaparib plus bevacizumab. And if patients are HRD negative or unknown, well, the jury is out, in my opinion. You can offer them bev alone, niraparib alone, or enroll them onto clinical trials. Well, so again, should we be just prescribing niraparib to all patients without a BRCA test or a HRD test? Technically, we could, based on FDA approvals. But the knowledge of the BRCA mutation status as well as the HRD status is still crucial for us to define the magnitude of benefit that these patients will retrieve both in the frontline and recurrent setting. And it's also important for the cascade testing of kindreds and family members and prophylactic interventions, especially for those with germline BRCA mutations or germline HRD-related mutations. So how should we be testing patients? And to me, I think the main strategy is really to test early. And remember, we need all these results to be available to us by the time the patients complete frontline chemotherapy, which is usually takes around 4 to 5 months. And on PAOLA-1, patients received at least 3 cycles of bevacizumab pre-randomization concurrent with the frontline chemotherapy. And, you know, if patient undergoes interval debulking surgery, we don't give bevacizumab within 6 weeks of surgery, meaning that we usually omit it with cycle 3 and cycle 4. And that really, you know, gives you a fairly short time for you to have those results before you decide whether you're going to prescribe bevacizumab or not from the time of diagnosis. Ideally, it's also important to test broadly. Ideally, that should be a germline BRCA test and a HRD test. Where available, the FDA-approved test is the Myriad MyChoice assay. Some physicians may choose to do somatic testing with the Foundation 1 panel, which would provide both the BRCA mutation status as well as other HR-related genes, and also provide the percentage LOH test, although this is not technically a FDA-approved companion diagnostic. But the idea here is to test as broadly as possible and to be sure that we can verify the BRCA status as well as the HRD status. Now, one remaining unanswered question is whether or not the percent LOH on the FMI test can be substituted for the Myriad MyChoice test. Indeed, we don't have direct prospective comparative data between both assays. One study I could find was presented at ASCO this year, and this was a very nice retrospective study from Gordon Mill's group. Essentially, the authors used 2 different cohorts. The first cohort was a very large cohort of more than 3,000 commercial samples in the MyChoice laboratory. And the second cohort was of 176 samples from the Scott Rock 4 trial, which is a frontline trial in high-grade serous ovarian cancer. And they analyzed all samples using the standard MyChoice GIS score. And they also used published methods to calculate percentage LOH score on the same samples. They also did a targeted screening panel for 11 different HR-related genes and tried to correlate these 3 methods of picking up HRD. So to me, the most important part of that presentation was the subset of samples with wild-type BRCA, because we know that by direct sequencing, we will pick up the BRCA mutants. So, to me, it's most important to be able to discriminate the patients who are HRD positive amongst the BRCA wild-type patients. And what was quite interesting is that when they looked at both methods, they found that 53% of patients that were MyChoice positive would actually be called negative by the percent LOH test, which means that, which is trying to imply that if you did a percent LOH test, you might miss up to 53% of MyChoice positive tumors. Okay, it is one caveat here is that this study, the authors did use the GIS cutoff point of 33 rather than 42. So if you imagine, this line here in the orange box, if you imagine that being slightly higher, okay, perhaps the percentage of cases being missed may be slightly less than 53%, but we do see that a fair number of the dots or of the cases do lie in this this orange box. And so that was my last slide. I would be very happy to take any questions, and thank you for your time and your attention. the dots or of the cases do lie.
And thank you very much again to both the speakers. Once again, thank you very much, Dr. Tan, who's actually an oncology fellow and resident physician at the National Cancer Center in Singapore. Thank you for your presentation, especially focusing on lung cancer. Thank you as well to Dr. Natalie Ngo, who's associate consultant at the National University Cancer Institute in Singapore. Dr. Tan, you might have a little bit of an echo. He's actually an oncology fellow and resident physician at the National Cancer Center in Singapore. Thank you for your presentation, especially focusing on lung cancer. All right, so now we can start with the Q&A. The first question, it's actually for Dr. Tan. And the question from the audience is about the discordance between FISH and NGS for rat testing. So the question is, thank you very much for displaying your paper, very interesting. But how do we move forward with that? So what is your practical suggestion? What people should do? Should they do both testing? Should they validate both of them, orthogonal testing? Or would you say, should they go forward with FISH or just NGS? If you could tell us a little bit more about that.
Yeah, so I think in our cohort, we had about half of patients that were tested with FISH and about 2/3 of patients that were tested with NGS. There are actually other, testing methods that are being developed, such as PCR tests. So these are all going to potentially come into play. It's something that, I guess there isn't really a gold standard as yet. So it really does need some, further clinical studies to really validate which one is the most accurate and sensitive. I think ultimately, with NGS testing in non-small cell lung cancer, it's going to become much more widespread and commonplace. So I think NGS is going to likely be the way that most patients are diagnosed. But, PCR techniques and may still have a role as well, particularly in, selected populations. So I think it's something that does require further study, but, there may be a role for NGS and PCR. I think in our experience, the FISH assay was not quite so sensitive. Obviously, we saw, significant rates of discordance, and potentially these are false positives. So, I think NGS will definitely have a role.
Thank you very much for your question. So, in other words, given that you were strongly advocating for having NGS upfront, this might be maybe the most likely solution. And then in case there is uncertainty or whether you are in a gray zone area, that would be the time when you will have to go and validate with another method. But you will still suggest that NGS should be the method upfront to actually test not just for rat, but actually also to look for other kind of fusion.
Yeah, definitely. I mean, I think it's especially in our population, in Asia, where, upwards of, we saw 70% of patients will have a targetable alteration, and the list of actionable biomarkers continues to, expand and grow. So it's something that multiplex, testing with NGS is something that obviously can detect all of these. There are trials, of RET inhibitors that are potentially going to use PCR techniques. So, there will still be some patients that may be diagnosed with PCR, but I think, if we think about in routine clinical practice, there's obviously a huge advantage for NGS.
Thank you very much again for your question, so for your answer. And now a question for Dr. Natalie. That's a tricky, nice one. I really love to get your answer about this. There's a couple of trials now that are looking for combination between PPAR inhibitors and checkpoint inhibitors. But the question is, how does test fits into this? Because now you will also need to look at a PD-L1 most likely, or even maybe potentially a tumor mutational burden. Nobody knows whether that it's really a good biomarker or not. Let's not get into that. But also, what about toxicity and, how will the combination work? Do you see as a sequential treatment combination at the same time. If you could tell us a little bit about that.
Sure. I think that the combination of checkpoint inhibitors with PARP inhibitors is really very interesting. And as we know, the tenet here is that the PARP inhibitors lead to increased cytosolic free DNA, and that triggers a CGAS-STING pathway and a type 1 interferon response, and that's supposed to synergize with immunotherapy. And I think in several trials, it has shown to be a pretty attractive chemo-free regimen. For example, in BRCA-mutated breast cancer, where they have pretty high response rates being demonstrated. And similarly, in ovarian cancer, for the germline BRCA1/2 mutated populations that are platinum sensitive, we have also seen on the Mediola trial, which is durvalumab and olaparib, that the response rate is around 63%. However, when we look at a group of patients whereby there's a higher clinical need, for example, in patients who are platinum resistant, the objective response rates actually aren't very impressive at all. There was a trial called the Topazio trial, and that was niraparib plus pembrolizumab, and I think the response rate there was only around 15 to 18%. So I think what's important is we're really trying to see which groups of patients are really going to benefit the most from such a strategy. Although the platinum-sensitive BRCA-mutated patients benefit with a high response rate, we also know that they benefit just as much from platinum-based chemotherapy. So can PARP plus IO, which is far more expensive than just carboplatin, can that really take the place of just the normal platinum-based chemotherapy? And in the space of patients where platinums don't work anymore, unfortunately, the response rates are quite low. And if we talk about what's a good biomarker to select for these patients, I think really this is an area of intense research. The HRD test, the My Choice test on the Topazio trial, it actually did not discriminate between responders and non-responders. And even on the Topazio trial, which was platinum-resistant ovarian cancer, the BRCA mutation itself also did not discriminate between responders and non-responders. Similarly, studies have been done in small cell lung cancer, gastric cancer, TMB and PD-L1. Some studies show that PD-L1 is helpful, and several other studies have shown that PD-L1 is not helpful, and I think none of the studies have shown that TMB is helpful. So that's where we are right now. There is a very nice publication from the Topazio study on Nature Medicine, that they looked at another investigational HRD test called Signature 3 or SIG3, and that itself did help to discriminate between responders. And they also did quite interesting, a deep dive into the tumor immune microenvironment. And they did also see that some interferon signatures that talk about T-cell exhaustion, they also help to discriminate the patients that respond to the strategy. So I think good translational work is really going to be very important in this space.
All right. So thank you very much again also for answering this one. And now we're actually getting to the end of our Q&A. I would like to thank once again Dr. Tan and Dr. Ngoy. Excellent presentation, very straightforward, both of them extremely hot topic. And also let me thank everybody for joining this session. Now we're going to have a 15-minute break. So please take the chance to have a coffee or also and the opportunity to visit our virtual hall. There's a lot of questions you can ask to our Thermo Fisher representative. Take the chance also to have a look at the poster in the Precision Hall. And there's a lot of practical resources and data that you can find there. So we'll see us again in this session in 15 minutes. Once again, thanks to the speaker. See you very soon.
Thank you.